Good evening, and thank you for joining us for this important webinar on telemedicine and COVID-19. I am the Georgia Academy of Family Physicians Director of Education, Felicia Keenan. I'm joined tonight by the leaders and staff of the Georgia Academy and the American Academy of Family Physicians. Also with us are experts on telemedicine and Georgia's rules and regulations, who will bring valuable information and resources for you and your team. Note that this webinar is being recorded and will be posted on our website on the morning of Thursday, March 19th. If there are staff members or other clinicians you think might find this lecture as a resource, feel free to direct them to our website located at www.gafp.org. The link to the webinar can be found under our COVID-19 resources. With so much information on COVID-19 being updated continuously, we are aware that some of the information you receive tonight might become dated, but we believe that the information on telemedicine will remain useful in the weeks and months to come. I would now like to introduce GAFP President, Dr. Jeff Stone. Dr. Stone is a practicing family physician from Canton. Please welcome Dr. Stone.
Well, good evening. As president, I'd like to welcome you to this free CME webinar. We wanted to offer this webinar as a benefit to our members during this ever-changing crisis in our state and nation. Please know that the recording of this live webinar will be available for others in the Georgia clinical and public health community to view by Thursday morning. We have a lot of information to share with you tonight. However, I wanted to take a moment to remind each of you about the importance of caring for yourselves and of each other. While most Georgians and virtually all Americans are being asked to stand down, as family physicians, we are on the front line and are being asked to step up. We're ready for this public health challenge, and who else knows how to quickly diagnose, treat, and triage our communities? It's what we've been trained to do, and many of us have been doing this for decades. As we are being asked to do more, please remember that you are Georgia's most valuable resource, and you will be pivotal in helping your community move through this pandemic. So take the time that you need for self-care. There are many resources on the AAFP website to support family physicians' well-being, and you can easily find them by going to the AAFP website and typing in well-being in the search engine to be directed to a myriad of resources. You should note that the GAFP leadership and staff are also working to support our members with continuous communication to keep you abreast of what's happening in our state. You should continue to contact staff by email or phone so we can assist you during this time of crisis. Now I'd like to turn it over to Dr. Ken Howard from Rome, this evening's moderator. Dr. Howard?
Hey, thank you, Dr. Stone. Good evening, everyone. I'm Ken Howard, your Education and Research Vice Chair and your moderator for tonight. We're presenting tonight's webinar on telemedicine and COVID-19 to provide you with resources and tools to ensure our members will have continuity of practice during the crucial time in our state and even in the world. The GAFP's Education and Research Committee is responsible for ensuring our educational programming is in accordance with ACCME guidelines, including the disclosure of significant financial interests or other relationships that they may have. For this webinar, each faculty member has reported their disclosure information to the GAFP, and you will note that information on one of the first slides of this presentation. Additionally, a member of the committee has reviewed each presentation to ensure its independence, free of commercial bias, and beyond control of entities with an economic interest in influencing CME content. Now, before we get started, I'd like to go over a few housekeeping notes. First, this webinar is being recorded. The recordings will be available on the GAFP website by Thursday, March 19th. Please feel free to share the webinar link with colleagues and other clinical and public health workers. We are offering 1.5 AMA Category 1 credit to those attending the webinar tonight. Now, if you are participating in the webinar along with others from your office or practice, please be sure to submit a listing of everyone in the room so we can issue credit to those who participated. Also, you will receive an email evaluation at the end of the webinar. We ask that you complete it and let us know your thoughts about the webinar and give us additional topics that you will be interested or you think will be beneficial for our members. We will cover a lot of information this evening, which is evolving. So GFAP will continue to place up-to-date resources on the GFP website. So please keep checking online for the most recent information. Note that the slides and all information referenced here are available for you to download on via the GAFP COVID-19 webpage. Expert CPT coder Steve Adams could not be with us tonight. Steve is well known to many of us as a keynote presenter at our annual meetings in the fall. Steve has sent some fact sheets related to coding for COVID-19 that were up to date as of March 15th, and you will find those resources available to you as well. Last item of business, you will notice that all lines are muted. Following the presentation, there will be a question and answer session. We ask that you use the question box on the screen to type your question, and Felicia Keening will present the questions to the panels at the end of the presentation. Please feel free to submit your questions at any time during this event. Tonight, we're fortunate to have a panel of experts to help us explore some of the many issues our practices may be facing as a result of the COVID-19 pandemic. Resources available from the AFP and other helpful information on adding a telemedicine component to your practice and how to get reimbursed appropriately. To kick us off, Emily Jones, MPH, Deputy Director of Government Relations, Georgia Department of Public Health. Faye Fulton, GAFP Executive Vice President, will give us information on Georgia's Department of Public Health, resources, and other Georgia-specific information you can use in your practice. Faye?
So again, Dr. Howard, thank you. My name is Faye Fulton, and I'm your Executive Vice President for the Georgia Academy of Family Physicians and the Georgia Healthy Family Alliance. I'm going to speak briefly, and then we're going to toss it to Emily to give kind of the latest information related to the Georgia Department of Public Health. The Georgia Department of Public Health resources, and that webpage is going to be what we refer to over and over again. Next slide, Felicia. The two key pieces related to the Georgia Department of Public Health and what they are updating on a daily basis is where are the confirmed COVID cases and what the age and the gender of each of those cases, as well as where the, I guess, hotspots are around the state. There is a general number for Georgia citizens who feel that they need more information that they can't find on the web page. It is a hotline number, but not your hotline number. The hotline number for the general population is 844-442-2681. Thank you, Felicia. Next slide. So this is what you're seeing on a daily basis, noting that it's being updated every day at noon. Next slide. This shows you the map actually is a little fuzzy, but you can see where the confirmed cases are by county and then age and gender. Next slide. Thank you, Felicia. And then this is just a quick, if you just want to check your county and surrounding areas, how many confirmed cases, and that's being updated by noon every day. Next slide. There's a lot of information that you can send to your concerned patients that will be helpful for them. This is also being updated on a quick basis. So, or on a timely basis, as a lot of this is changing. So we recommend that you utilize these resources and send this information out to your patients. Next slide, and probably more important, the slide related to the guidance for healthcare professionals. So this is again on the Georgia Department of Public Health webpage, and note that it's already been updated and it's an interim guidance, and it is being updated on a routine basis and regular basis. Next slide. You will see, and I know that Dr. Julie Wood will also be talking about the resources that are on the CDC website, and it's important to know that that the CDC and the Georgia Department of Public Health are working in tandem. The other part that is maybe the most important information that I can give you, which is testing triage. This is a number for clinicians that we are asking that you guys utilize when you are working through a potential COVID case. Next slide. And that number is, if you don't already know it by heart, it is 866-PUB-HEALTH, 866-PUB-HLTH. And I'll pause now to make sure that Felicia can bring in Emily Jones with the Deputy Director of Government Relations. And Emily's going to be with us for a brief amount of time because she has another meeting to go to, because when you work for the Department of Public Health, your work never ends. And she's going to briefly give us kind of the latest on some of your key questions that we know we've been hearing and you've probably been asking around as well. And Emily's going to speak to it. She is not going to be able to stay on the line until the end of the call. So if you'll go ahead and type your questions to Emily, Felicia will make sure that those questions are given to her. And I am now going to pause and ask Felicia if you have gotten Emily into the call.
Hey, can you hear me?
Yes, I can. Welcome, Emily. I really appreciate you joining us. And I know that you're working, hopping from one meeting to the next. So as we talked about this morning, I think some of the most often questions that are coming up are related to Georgia testing sites, kits, as well as PPE and Georgia supply. So I'll toss it to you, Emily, to give us that update.
Sure. Thank you so much. And thank you all for all that you're doing. We know that this is a very difficult time and situation, and things are changing almost hourly as we move forward. So we really appreciate all that you're doing on the front lines and your willingness to hear from us and to work with us going forward. So I do want to address, and I know that this is kind of on everyone's mind right now, testing kits and PPE. We are very aware of the situation regarding both of those. One thing that I will say is I think you've probably heard a lot of people at the federal, state, local level talk about ramping up testing kits. We are going to be getting more testing kits. It is not going to be like they're just available to everyone. We are still really looking at priority patients and triaging tests for those that are considered to be, you know, a priority or a higher risk population. That includes the elderly, those with chronic underlying conditions, and healthcare workers. In terms of looking at who gets a test, we are getting more in the next couple of days, and we anticipate more coming in the future. We are also rolling out our testing sites this week. Some of you may already have heard from your local health leadership about this, but the testing sites will be available in all 18 health districts. They will be by referral only. So we have been sending out guidance that some of you may have received on what that kind of referral process is going to look like. Of course, we're very aware of the world that we live in, but at this time, we are sort of asking people to keep the locations of the test sites private, because we are not taking walk-ups. We are taking referral only. So again, those instructions should have been going out in email. I know that they were out to our districts earlier today, and I believe the plan was by tonight that they would be out through a variety of different email listservs. But that guidance is available, and if we need to float it out through the family physicians, we can also work on doing that as well. In terms of PPE, this is a very difficult situation. There is a national shortage. We know that the manufacturers are putting limits on sort of what you can order. So we are working with the Strategic National Stockpile to get more in. I would say that it goes out as quickly as it comes in. And unfortunately for you all right now, our priority is hospitals because of they're also having a lot of the cases end up in the ICU. So right now, what we are really encouraging is if you all have existing contracts with manufacturers, I think I've been under the impression that many of those manufacturers will honor the contracts. They will not start new ones. So we've been trying to encourage people to sort of create like a network within themselves, within the medical associations, to share a potential contract, so where one would order and then share with the others. But we do know that that is a very big issue right now, and we're doing everything we can to get PPE in through the federal government as well as through private contracts in any way that we can get it to you all as quickly as possible. We also, in terms of testing, several commercial labs have started doing testing. So LabCorp and Quest are two. We have also heard that potentially Kaiser is either able to do it or is willing to do it and is in the process. So if you have existing contracts with any of these labs, you can refer patients, or you can send testing specimens to those labs instead of the public health lab. We're still very limited in what we can process at this time. So again, we encourage you to reach out to the commercial labs that you may already have a relationship with. We also know that there's a lot of confusion about who is actually collecting the specimen. So we are telling people to call their healthcare provider, which is primarily going to be you all. We are not collecting specimens at the local health departments at this time. We will be collecting specimens at the testing site. So if you all feel that it is safer or more appropriate for you to refer to the testing site, then we encourage you to do that. Otherwise, we are encouraging you to work with your patients to bring them in either through a back entrance or after hours, so that you all have the time to, put on your PPE, and so that you don't expose other patients that may be in the waiting room. Our biggest issue is people showing up at the ER. So even if you can't collect the specimen and you can't get them to a testing site, please discourage them from showing up at the hospital. They can call the hospital to try to receive a test that way, but we really need to discourage people who might be sick from showing up at the ER for anything less than an actual emergency. It's really not the route that we want to go. We are hoping that as we get more test kits and as we hopefully get more PPE, we can expand the number of people who are collecting specimens. But we are still in the early phases of rolling out all of our testing sites. We anticipate them being all up and running by the end of the week, but with a very limited supply of tests. So, again, we have priority patients that will get priority for testing. And we are doing everything that we can, and we will continue to keep you updated as things move forward. I would also, again, encourage you that if you are calling, to call the 866 Pub Health line. That will get you to a medical epidemiologist faster. If your patients have general questions or concerns, the 844 number that is on our website is appropriate for them to use as well. We're really trying to triage. We're getting over 1,500 calls a day, and trying to triage, which ones are need a med epi versus which ones don't is getting a little difficult, but we're doing the best that we can. And, again, as with everything changing so quickly, please continue to check our website and the CDC website for guidance. We are following the CDC guidance, so if the CDC says something, then we agree with it. We know there's a lot of questions and concerns about business closures and, primary care closures and dentist closures and all these kinds of things that are floating around in other states. But as of now, we are discouraging. We're not mandating closures. We're not mandating any quarantine measures or anything like that. We are really just working in tandem with the governor's office and the CDC to ensure that we're doing everything we can to, promote social distancing. We're trying to promote that patients delay elective procedures as long as they can, and work with you all to make sure that you're not overwhelmed and that, your practices aren't overwhelmed and things like that. So I'm happy to take questions for a bit. I'm sure you guys have a lot of questions. I may not have all of the answers, but I will answer anything that I can. And, again, this is such a fluid situation. It really is just changing very quickly.
Thanks, Emily. I really appreciate you taking the time. And I know that Felicia has a couple of questions already in queue. Again, if anybody wants to ask a question for Emily, go ahead and put it in the chat box, and Felicia will read them to Emily. And Felicia, I'm tossing it to you for the couple of questions I know you already have ready for her.
Sure. The first question is, can the state release supplies that are in the National Strategic Stockpile, i.e. masks and PPE? This is definitely an emergency situation.
So we are releasing them, but our priority right now is hospitals, particularly because we have hospitals with a significant number of hospitalized patients. There is a form you can fill out to request PPE from the Strategic National Stockpile. I don't have it on our slides, but I can get it to Faye tomorrow. But I will emphasize again that unfortunately right now with the limited supplies we have, our priority has been getting it to hospitals.
Okay. The next question is, the 866 PUB health lines as of this past Saturday was a loop message. Number one, severe points are affected medical professionals, and number two, was this just a mild case? And there are no persons by St. Mary's Healthcare in Athens. Was the line to get in Athens, number 7, was the line to get a person? However, this information was not in the phone message loop.
Okay, I think the question that it sounds like someone's actively typing while Felicia's trying to read it, but I think the question is, how is the 866 number being staffed? And also, I guess there's a question specific to the Athens area. Emily?
So in terms of staffing the Pub Health number, we are staffed through our Emergency Operations Center. That is a variety of our epidemiology team, internal emergency preparedness staff, volunteer like medical students and other healthcare workers who are not paid by DPH but who are there on a volunteer basis. And it is primarily a mixture of those people. We do have, when we run our Emergency Operations Center for things like hurricanes, we have people that we deploy into that position. And so it's a lot of those same people. I know that it is not a perfect system. We are working very hard to, again, as I mentioned, we have 1,500 calls a day. Most of them are not coming from clinicians. We are doing our best to triage, and I know that sometimes it doesn't work. It is sometimes a loop for people who may not need to speak with a medical epidemiologist. If you have a real concern, I would say that you can email. There is a constituent services account for DPH. It is DPH-constituent services at dph.ga.gov, and I'll get that to Faye tomorrow and flag it for us, because we know that we are not catching everyone that we should in that number, but we are doing the best that we can. It is just very difficult to triage through the phone tree who should go where.
And then, Emily, in terms of the Athens specific question, I think you kind of addressed it in the sense that the testing sites are being sent out now, and we will absolutely send that out through our channels as well as posting it online, which might it might not have helped for over the weekend, but now that there's going to be a more coordinated district public health testing sites, we'll absolutely be sending that out to all of our members and having it available to anyone who stumbles onto our website. Felicia, are there other questions for Emily?
There are. There are two asking what are the criteria for testing and what would the plan look like in the next 2 weeks?
So in terms of the priorities, I have the document. So per DPH guidelines, the people who should be prioritized for testing at these specimen collection centers include healthcare workers and other first responders who frequently interact with vulnerable populations, people working with and caring for vulnerable populations such as long-term care facility staff, people living in congregate settings where the disease can spread rapidly, and other individuals include the elderly and those with chronic underlying conditions. We do say, and we've discussed this with the pediatricians, but pediatric patients will very rarely be priority because we do tend to see that the condition is almost non-existent in the pediatric population. We are working with them specifically as well on some pediatric specific guidelines.
Thank you, Emily, and we'll need that as well since many of our members also take care of children and adolescents. So if you'll make sure that we're looped in on what you're sending out to the pediatricians so we can get it to the family docs who are taking care of children as well.
Yeah, sure. That's actually coming from the pediatric, the Georgia AAP. So we just kind of looked it over to make sure that their resources for our guidelines were correct. But that is something they're distributing and maybe have already distributed, but I'm sure we can get that shared as well.
Perfect. I appreciate it. Next question, and I know we're running out of time for Emily, and we've got a lot more to go. So, Felicia, maybe the best or the one most frequent that you've gotten in the chat box.
Yes. So this question is, should providers get tested to make sure we are not transmitting to patients?
So I think our guidance on testing providers has to do with a potential point of exposure. Just generally, we're not recommending it because we're still limited. But if you have a confirmation that you have interacted with a person who tested positive in a way that puts you at risk, then yes, providers are considered a vulnerable population because, again, you have, as to your point, you have the potential to spread to so many other cases.
Thank you, Emily. I really appreciate the time that you've taken. I know that we've run out of time for you, that you are heading off to get another call shortly. And if there are questions that are unanswered at the end of this call, we will have a copy of all of the chat questions and we'll direct them to DPH, and we'll make sure that Emily gets that. Our websites are up and moving, so we definitely want to be there for you. And with that, I will toss it back to Dr. Howard. Thank you so much, Dr. Howard.
All right, thank you, Faye. You can find all the resources that Faye mentioned on the GAFP website. Staff is updating that information daily. Next, I'd like to welcome to you Dr. Julie Wood, Senior Vice President of Health of the Public, Science and Interprofessional Activities at the American Academy of Family Physicians, who will tell us about the national resources available regarding COVID-19. Remember to type your questions into the question pane. Dr. Wood?
Hi, thank you very much, and I appreciate being here tonight and sharing what we've been doing at the AAFP to support you while you're out in the trenches, and I look forward to your questions as well. We have a number of resources. Faye mentioned the CDC. What we've been trying to do is take the multiple changes, as you heard, have been coming in often daily, more than daily. If you start out and look at our COVID site, if you could advance the slide, please, Felicia, or whomever's doing that. Or I'll just talk about it. We have a website you can get to right off of AAFP.org. That's a COVID-19 site that will help you get through all of that information very easily. And that is at AAFP.org. We have a checklist for your office for preparation, or you're obviously already on the way to taking care of folks. We've updated that yesterday. There we go. And you can go ahead once more. We have a COVID-19 that meets every day, sometimes twice a day, to update things as they come in. There you can see it right now, so you can get there. And there's 3 boxes. We have an advocacy area. Also, one of the things I wanted to encourage you to do, if you see there's a speak out, many of you may have already done that before. We have started a grassroots campaign so that you can go in and talk with your congressman at the federal level, so that we can talk particularly about some of the key issues. We are hearing sound very similar to what you're doing there in Georgia. Top issues have been around PPE and access to that, around testing shortages, and it sounds like you have some better integration with your health department, but many folks are not doing as well around the country as far as communication with their health departments. But we would encourage you in Georgia and around the country to reach out onto that speak out. The middle box that you'll see there is the COVID community. That's a member exchange. It's an online community for members. It's getting quite robust. And if you would be so kind as to hop on there and sign in, it's about 500 members now, and everyone is sharing ideas. And staff are on there regularly so we can answer questions. So if there's something that you want to talk to us about, you can always email us as well. But we're available to talk about any number of things. And members are also sharing resources back and forth. And then we have our preparedness checklist there that you'll see. A new feature you'll see on the website today is a daily update. And so it'll be more of a capsular overview. When you get onto the main COVID webpage, as you can imagine, with all the CDC and other resources, it gets pretty busy pretty quickly. So one of the updates that we've gotten from members is that, especially when you're a practitioner seeing patients all day, every day, it's pretty overwhelming, and they just want to see the down and dirty, what's happened today? What do I need to know? What are the updates? So starting today, we started and this picture was actually screenshot yesterday, so things changed that fast. We put in these daily updates so you can see a quick capsular view of what happened today and what changed today. So you can click on that and see that. So we encourage you to just go on AAFP.org today, and you can see quick updates of what has actually changed today. And that will hopefully help you see that in a quick manner. From an advocacy perspective, I wanted to update you that we have been sending many letters. If you look at Funding for Family Medicine on our webpage, it's concise. And if you're interested in seeing what we've been doing, we've been very active. Today, Doug Henley was on the phone with Vice President Pence and President Trump. They had a call with all the major medical organizations, including the AMA, and then the multiple other specialty societies. And they were asking about all of the key areas that you can imagine. We were very pleased to be there and share our opinions about what we thought needed to be done and what was still a concern. Many of the things that you've heard about on the phone so far. So I'd be glad to answer questions about that and what we learned today. But we're continuing to advocate for those very concerning areas. But those are the main areas that we have for education. I would encourage you to go on the webpage, and we'll be continuing to update them. One of the things you're going to start seeing, I think it's going to be on Saturday, Dr. Leroy wants to start doing a at least weekly webinar and do some town halls. He thinks that it will probably start being more midweek, but he wants to get one going, and it'll likely be on Saturday, but we don't have it confirmed yet, but you'll see those very soon. And I think there's maybe one more slide that has just a little bit of listing of other websites.
Thank you, Dr. Wood. And then again, there's a bit of a change up. I know that Dr. Wood can't stay for the bulk of the call. So if you don't mind, Felicia, we'll pause if there are any questions directed to Dr. Wood as it relates to the AAFP. If people can go ahead and text that now. I will say from the chapter staff, in terms of information, we have been well informed along every step of the way. and really appreciate the AAFP's resources. And Dr. Wood immediately agreed to hop on this call, as busy as she is, and with the myriad of details that she's trying to work through and support our members nationally. So Dr. Wood, I really appreciate it. And Felicia, I'll toss it to you in case there's any specific AAFP questions in the chat box. And then again, if you think of questions for the AAFP after Dr. Wood dials off into her next conference call or activity, maybe even dinner, then we'll push them out to you and your staff, Dr. Wood, and make sure that we connect you with anyone if they've missed the opportunity to have a question for you.
That sounds great. I really encourage you to sign on to that community. It's a really amazing set of resources. We're following it closely. We're learning a lot from you as our members, and we want to be responsive and get you what you need as much as we can. A lot of it's really tough right now because we can't get into the stockpile. We can't get you a mask. We really want to, but we can't yet. But there are a lot of things we can do, and we're working hard on the advocacy front as well as what resources we can get you. So we want you to know we got your back, and we'll continue to be a loud voice for you. And whatever we can do, we will do our very best. So please keep your questions and comments coming, and feel free to email me. You've got my contact information there, and we want to continue to be your voice.
Awesome. Felicia, any questions for Dr. Wood before she pops off?
Yes. First question.
And I mean that in a nice way, not in a bad way. Go ahead.
Are there any resources on how our primary care officers can get appropriate PPE?
I wish I knew. We are working really hard on it. We did hear from the president today that he signed an executive order to, basically a wartime order to increase production. They have plans to increase production in a number of different ways. One of the things that Dr. Henley talked to the president about on the phone call today was prioritizing getting that to the front lines in primary care, not just getting it to the hospitals. With all due respect to our hospital colleagues, we need it on the front lines with our family physicians. And so we'll be continuing to work on that. Like you heard from our public health official, that's great to get it to the hospitals, but we need it on the front lines. We need it, our staffs need it. So I can't give you anything any different from a national level. We can't get a hold of anyone to actually get it to you, and I wish we could, and it's a big frustration for us as well. But we are trying to find a number of different channels to help increase the production and the distribution. Every day we're working on it. It's a tough one, but it's extremely important.
Alicia, any other questions?
At this time, I don't see any other questions for Dr. Wood.
Thank you, Dr. Wood. We really appreciate your time tonight.
Thank you. Thanks for having us, and we will keep working on it for you.
Okay, thank you, Dr. Wood. We really appreciate that. Please take a moment to type your questions in the question pane, just like they had said, and we'll cover all the questions at the end. Again, getting those available to her later on to review. Next, we would like to welcome Marina Brewer, Chief Executive Officer from the Global Partnership for Telehealth. Global Partnership for Telehealth is a nonprofit organization with a worldwide footprint that is based in Waycross, Georgia. GPT offers telehealth technology solutions and web-based platforms that bring much-needed healthcare resources to urban and rural communities with a focus on underserved areas. Ms. Brewer will provide both legal recommendation and applications to quickly and successfully implement or expand telemedicine in your practice. Ms. Brewer?
All right. Thank you. Can you hear me and see my screen?
Yes.
Perfect. Global Partnership for Telehealth does serve the state of Georgia as the statewide nonprofit network. We also serve the region as the Southeast Telehealth Resource Center, which is federally funded program to push out and advance telehealth in the 4 southeastern states. We are part of a national consortium of telehealth resource centers. There's 14 across the country, and we are sponsoring a national webinar tomorrow at 2 p.m. With some national experts speaking. If that's of interest, you just need to Google telehealth resource centers, and it will take you to our website, and you will find registration right there. Tonight, what Troy and I are going to do is quickly talk about telehealth during this period. So telehealth offers exceptional capacity for remote screening, triage, and treatment, and could be a powerful tool for reducing transmission of the disease to and among healthcare workers and patients who are not yet infected. So here are the learning objectives for tonight. I won't go over those for the sake of time. CDC is saying that community mitigation is a set of actions that persons and communities can take to help slow the spread of respiratory virus infections, and community mitigation is especially important before a vaccine or drug becomes widely available. Here, the CDC has on their mitigation activities grid, if there is none to minimal risk, they're saying as far as telehealth, develop systems for phone triage and telemedicine to reduce unnecessary healthcare visits. If what we see here, let me, oops, that got too big. Let's see if I can reduce that. Anyway, what you can use telehealth for in the community is for isolation patients who cannot come out, for care for those who have already been diagnosed, and for remote patient monitoring. Oh, here I'm having trouble. Enter. Okay. All right. What we got here is a screening model that has been implemented. It's a frontline screening model with the Grand Rapids-based Spectrum Healthcare. They have 15 hospitals and 11 urgent care centers. And according to their chief medical officer, Dr. Elmushi, telemedicine is a perfect screening tool. And you can see that the benefits listed there, it's much more convenient for people to be screened in the home rather than having to visit an emergency room or a care center. And if you can screen them, the screening we're talking about is an assessment that you do, a face-to-face assessment with that patient in the home. And hopefully they would have a thermometer that they could talk about. But your ability to look at them and hear their breathing and all that is a good starting point for initial assessment. And from a public health standpoint, telemedicine screening in the home keeps these people from coming into the healthcare setting where there are patients that might have COVID, and those people need to be there versus those who are in for screening. So to protect everyone, we should keep them away from the healthcare setting. And then finally, the telemedicine screening can help prevent the spread of the disease to those who are critically ill. And hopefully, you know, once you assess them, if they need screening, an actual test, then you arrange for that, and then treat them at home unless they need urgent care or more serious care. You know which patients are candidates for virtual telemedicine? Non-COVID patients, those that are at low risk, patients with chronic diseases, those are at high risk, and then those who have a presumptive positive or a positive test and they are in isolation at home. So when you break down the different types of patients, patients who are not at risk for COVID-19, these would be people who are experiencing no COVID symptoms, but they need medical attention. They're having issues, and a lot of these can be treated like the direct-to-consumer model that's been in effect for years now. You could treat your patients at home. How would you do that? Well, the patient has to have a reliable connectivity, internet connectivity, and then some appropriate device, whether it's iPhone, PC, whatever, iPad, and then some kind of software that would enable the two of you to connect. Okay, let's go to the next one. All right, those patients who have presumptive positive or positive, those that are experiencing mild symptoms with no risk, patients can safely isolate at home while having virtual contact with you, the provider. And this does prevent the unnecessary need for patients to travel. And here again, what do you need? They need reliable internet. They need a device to be able to connect. They need an app for the video conferencing ability. And then if they have some kinds of devices, blood pressure cuffs, the thermometer, that certainly is desirable as well. And I had skipped a slide about those who have chronic diseases. I don't think that's next. Yeah. So to keep them away from healthcare settings, if you could monitor those patients at home, you can implement remote patient monitoring during this time, and there are companies, Georgia-based companies right now, who can help you immediately deploy these devices and help with that monitoring process. Telehealth considerations for providers, licensure, you have to have an appropriate license. You're expected to practice within your scope. If you're going to work with a hospital and patients are in the hospital and you happen to be a specialist beaming in, there's some credentialing that should be tended to. I think Troy is going to deal with the Ryan High Act and his, and even though there's some leniency now with security and privacy, you still need to safeguard what you're doing and with these patients. What about hardware and software? And this is from CMS. Let me see if I can get rid of this. Specialized equipment needed to furnish Medicare telehealth services under the new law. And currently, CMS allows for the use of telecommunications technology that have audio and video capabilities that are used for two-way real-time interactive communications. The new waiver is saying that the secretary is allowed to for you to use the telephone, but it does need to have some video capabilities. In addition, the HHS office will exercise enforcement discretion and waive penalties or violations when it comes to their normal guidelines. Right, this is just a workflow that you set up. It's simply, you've got to create logistics. How are you going to connect with these patients at home? How are you going to set up the appointments? Some systems, telehealth systems, have a built-in scheduling, but you don't necessarily have to have that. You can use your in-house scheduling. Then you set up a place to interview and screen patients that is private, whether it's your office, your home, wherever. And then, a workflow of determining treatment and following through with that. And you'll be able to look at these slides on your own. All right, what about private insurance plans? They right now are stepping up the plate and making some changes. And this information came from America's Health Insurance Plan, which is the national association whose members provide coverage of health care and related services across America. Here's what Aetna's doing. They are going to waive copays, and you can see the different things they will do here. So we got Anthem stepping up to the plate, and here are their agreed waivers and considerations that they're making. And then we have Humana, who's also, and I would think every insurer across the country is stepping up and providing some kind of relief in regards to this. And for now, I will go ahead and exit and let Troy take over so we can cover reimbursement and get to your questions.
Thank you, Ms. Brewer, for the great information on that telemedicine. That is so crucial during this time of uncertainty, especially in the healthcare. Our last speaker of the evening is Troy Heidish, founder and chief executive officer of Smart House Calls Telemedicine, a startup biotech specializes in telemedicine applications for healthcare and mental health professionals and organizations. He will provide guidance on properly coding for telemed services, which is a crucial piece to this telemedicine puzzle. Troy has his doctorate in nursing and has been working on telemedicine and reimbursement for telemedicine for over a decade. Mr. Heidish. Troy, are you there?
Sorry about that. Forgot to hit unmute. So sorry about that, gang. So
no problem.
First, I want to thank everyone for all the work that you're doing. You really are on the front lines when we're talking about family practice. You're taking on a lot of risk and you're doing a lot of service, so thank you for that. The other person that I've twisted their arm and has offered to jump in and make sure that I stay on track is Steve Adams, and I don't know if he has unmuted his phone or if he's available. Thank you. All right. Basically, I want to just briefly get into, and I want to leave as much time for questions as possible, especially considering all of the work that's ahead of all of us and the newness of a lot of this idea about technology and telemedicine. We've heard about it for a long time. We've probably done it for a long time, but not maybe in this way. So I want to make sure that we have plenty of time for questions as we move forward. So I'm going to skip through a lot of these things. So some of the basics again, I'm going to hit this very briefly. There's 4 basic types that I tend to think about. We have that live video conferencing piece, which is more about what I will be speaking to, the stored and forward opportunities where, you know, maybe a patient takes a picture, sends you an image, and then you evaluate that and make some recommendations. And there's health applications and smartphones, remote patient monitoring. And I've got some examples there as well of some of the larger companies that are doing things within this space. Some of the enablers that we've seen for the possibility of telemedicine, and I've got an old picture from the 1930s and 40s of a physician evaluating a patient via a TV from a popular science magazine. So we've been talking about this for a very, very long time. But things are rapidly changing with the growth of the broadband, growth of mobile 5G technology, which we're really excited about in the telehealth industry. We're seeing tech-savvy customers, and I would say that one of the common questions I get are, what about those geriatric patients that we take care of, those that, how are they doing? What we tend to see is that a little over 80% of them are using the internet regularly, and over 50% of them have smartphones already. So while you may not have 100% of your clients to be able to use this sort of technology, that you're going to find that more do than you thought really did, and they'll sometimes surprise you with how tech savvy they are. Third-party reimbursement is improving, and that's especially true today over the past 2 weeks. Remote patient monitoring, clinician shortages, grant funding, and patient satisfaction and improved health outcomes. Those are all driving what we're doing in telehealth. But more what I'm talking about today is I want to look at some of the improved outcomes that we're seeing. And I add this in there because sometimes even when we feel like it's necessary, we're sort of scared to act because we fear that maybe patients are going to be taken as well care of if we're trying this new technology. So I'm going to touch on that briefly. Telehealth can reduce costs. We talk about patient visits and them driving there, but also there's some capital costs that save physicians money in the practice as the practice grows. And then as Rena talked about COVID-19 and the 1135 waiver, this greatly opened up your ability to really use telehealth in your practice. So, but is telehealth really the answer for everything we're looking at, COVID or is forward? And I would frankly say no, but it definitely can be a part of the solution. We shouldn't think that we are going to replace our face-to-face visit with patients and simply go all digital. I don't think anybody really believes that, and I need to make sure that you all understand that those of us in this technology sphere understand that as well. So briefly, we talked about the Ryan-Haidt Act, and to give you a little bit of history on this, if you're not familiar with it, essentially it was a teenage boy who, a perfectly normal athlete, had come home, said he was going up to his room to go to bed after a sporting event, and the next morning his parents found him and he had expired in his room. And what was discovered through the investigation is that he had gone on to online chat rooms and through an online pharmacy and had purchased narcotics and had overdosed. And since then, and because of that, they passed into law the Ryan-Haidt Act, which essentially prevented these online pharmacies from sending medications to people through by the internet and then delivering it to them. But what I'd say, there's been some questions, some concern about what does that mean for telehealth providers, and what does that especially mean for me if I happen to see patients through telehealth. And what I would say is that even prior to this, there is an exemption that's been carved out within that act that recognizes telehealth as a face-to-face evaluation, especially if you have a established relationship with this particular patient. So in the healthcare industries, I should probably just skip through this, right? We know that there's a physician shortage and it's getting worse, and we're especially not only as baby boomers age, but really our baby boomer physicians are retiring as well, and they tend to like to work more than us Gen Xers and millennials. So, you know, we've got some issues here, and telehealth is being seen as a possible way to bridge that. So some of the outcomes I wanted to talk about, what we've seen from physicians when they use telehealth is that they really do feel that they get the patient's concern, that they got the pertinent physical exam information that they needed, and that they appropriately felt that they treated the patient's problems. The other sort of face of this is that antibiotic through telemedicine, some research is showing that it's the same as face-to-face, and others are saying that, well, actually what we're seeing is a poor performance in appropriate antibiotic treatment versus face-to-face. So we've got some conflicting information out there, and I think it's fairly easy for all of us to understand that we're going to have some physicians and some really nurse practitioners, PAs, who will treat more conservatively, and they'll tend to overprescribe antibiotics in that situation, and that's probably driving some of that from the telehealth perspective. So what we also see is that telemental health is effective and is similar to face-to-face visits. We have also seen that telehealth may actually be better, or telemental health may be better than face-to-face for adolescents. They just tend to feel more comfortable in front of technology than they are sitting in the office with a psychiatrist or a therapist in the same room. We've seen that telemedicine greatly improves diabetic response over traditional care in some ways. And in fact, a research study that I was involved in looked at remoting in diabetes educators from a local hospital into a rural family practice office that was about 45 minutes away from the hospital. And what they saw is they dropped no-show rates from about 40% down to less than 7%. And they saw a decrease in A1Cs and also saw a decrease in obesity with that. So we're seeing some improvement there. And then 98% of all medical telemedicine consults did not require follow-up exams, and 92% of those patients said that they would use it again. So patients are accepting what we're doing. The other piece of this puzzle, and the one that you're probably most interested in, is really getting into how are we doing as an industry using telehealth and having it reimbursable. And what I will say here is that we've got, I don't know if you have heard of parity laws versus coverage and reimbursement parity, but essentially what we're looking at here is that most states require that insurers pay and third-party reimbursers pay for telehealth at the same rate as you would expect if the patient were face-to-face. And I'm happy to say that Georgia was one of the first, thanks much in part for the Global Telehealth and what they've done as an advocacy group, but also some of our legislators really saw the need with our rural counties that we needed to do something and really lead the nation in this. And there we go. So just some very brief statistics on how this is being adopted. 50 states in Washington, D.C. provide reimbursement. 11 states provide reimbursement for store and forward, which is what I said, taking a picture, sending it, email exchanges, those sorts of things. 21 state medical programs, Medicaid programs provide reimbursement for remote patient monitoring. And 23 states limit the type of facility that can serve as an originating site. That really hasn't changed from 2019 to 2020 until, frankly, until about 2 weeks ago. 34 state Medicaid programs offer facility fees. So what that means is that if you happen to be, as a family physician, if you happen to have a patient and you have a specialist, an endocrinologist that remotes into your office, not only does the endocrinologist able to charge for their services, but you're able to charge a facility fee. 39 states and DC currently have a law that governs private payer telehealth reimbursement policy that really hasn't changed up until the last couple of weeks. And 14 states allow home as the eligible originating site, and that has also changed in the last 2 weeks. So traditionally, what we've seen is that facilities, the patient from the CMS standpoint had to be at a location that could bill for services. That could be a physician's office, rural hospital, critical access hospitals, tertiary care centers, That's what we had to deal with. The best way, and there are ways, and the person from CMS perspective also had to be in a rural or underserved area. Visits, though, in those situations were considered the same as in-person visits and were paid the same as those. In 2019, Medicare started making payments for brief communications or virtual check-ins. They couldn't be, these virtual check-ins, and maybe many of you know about these, but they couldn't be within 24 hours of an office visit or the first available office visit. They could be done over the phone, and Medicare Part D separately pays clinicians for these e-visits when the patient initiates communications, not when the physician does or the office does. So traditional requirements for payment for telehealth, here's just some CPT codes and this goes back to these new changes. These codes, again, were used for use when E&M services are performed. That type can be done face-to-face through HIPAA-compliant secure platforms. As I said, though, these have to be patient-initiated communications and may be billed by the clinicians who independently bill for the EMN service. And here's just some of the typical fees that are associated, or reimbursement amounts that are associated with those, as well as the billing codes. And these will all be available, again, through the website. Most typically, and when I talk with physicians and physicians' offices about how they're going to use telemedicine, typically we're used to those CPT codes 99201 through 99215. If patients in their office, typically our most common codes are 99213 and 99214. So often I get the question that, well, I can only really bill a 99211 or a 99212 for my established patients if I'm using a video conference, but there are cases in which, and I'll have Steve jump in if he thinks I'm incorrect here, that you could bill a 99213 for a telehealth code, even if you're just using audio, video with a patient in their own home. You could have an expanded problem-focused history. You could have this expanded problem-focused exam, a low-complexity medical decision-making, or 15 minutes that you spend with the patient face-to-face.
Yeah, what CMS has done now is they've allowed us, because of this pandemic crisis, to let you bill, even if it's a new patient encounter, if you do telemedicine through a audio-visual format. And I'm sure Troy's going to talk about the exception now is that you can do it FaceTime. You don't have to be HIPAA compliant, but you do have to have audio-visual. But you can bill these codes, even though you're not physically touching the patient, still based on time, because they are considered face-to-face visits. So a 99202 is a 20-minute visit. That might be, unacceptable because that requires all three components. But a 99201 is simply a 10-minute video conferencing. And then, like Troy said, you can bill the subsequent visits. A 213 is a 15-minute face-to-face visit, and even a 214 would be a 25-minute face-to-face. So what we're kind of advising doctors to do is to kind of think of telehealth in three different, forms. There's one form where it's physically just over the telephone, which I'm sure Troy's going to go over, which is the G2012 for Medicare carriers, and for commercials, it's 99441 to 99443, and that's, again, phone only. And then there's through your portal, electronic, which Medicare came out with and the AMA came out with in 2019. And Troy's went over those codes, 99241 to 99243, and it also has some G codes for your mid-levels. And then during this pandemic, national emergency, CMS is allowing us, as is Medicaid, to bill telehealth services that Troy's talking about without having an originating site. So you can bill these as regular face-to-face visits like you would, and I would suggest billing them on time. And just remember, when you document an E&M on time, it's your total face-to-face time, more than 50% was counseling, and the topics that you discussed. And then when you bill those E&M codes with the audio-visual component, most commercial insurance companies require you to use a modifier 95 if you're taking notes, and a place of service of 02 to indicate all those codes were telehealth-based services. And commercial carriers want the 95 modifier. Medicare just requires the O2 place of service. So when your billers are filling out your 99213 for an audiovisual FaceTime, if it's Medicare, it'd be 99213 and just place of service O2. And if it's Blue Cross Blue Shield, it would be 99213 modifier 95 place of service 2. So there you go. That's it. So Troy's got some of the coming up.
So, so I wanted to sort of, I found the website from CMS that had some Medicare-specific telehealth frequently asked questions, and how does a qualified provider bill for telehealth? And that's simply what Steve was talking about, is that the services are generally billed as if it's been furnished in person. The Medicare telehealth services should reflect the design place of service, the O2 code. Telehealth indicated that it was billed and was furnished by a professional telehealth service from a distant site. And when we say distant sites, that certainly can be the patient's home. But frankly, since CMS is now allowing the use of smartphones as a telehealth, I could see where you have a phone call coming in from a patient and you do a telehealth visit, having them wait in their car and taking a testing kit out to them, or advising them on how best to proceed to be tested and what you feel like you need to start treatment in, as opposed to having them walk into your office and having to physically be in the same room and put yourself at risk. You definitely are vulnerable populations out there fighting this. Let's see. So, what's happened since? And Rena covered this beautifully in her presentation, but it's waiver 1135, and really this has opened up your ability to treat patients at a distance much more than you've ever been able to do before. And this was signed in March 6th, or it was started March 6th, 2020. And those who can bill for this service and charge for this service are doctors, nurse practitioners. It doesn't say PAs in here, but I'm fairly certain that physician assistants can as well. Clinical psychologists, licensed clinical social workers can all do this. You can bill for services through telehealth, including the evaluation and management visits or common office visits, mental health, counseling, and preventative health screening. The provider must use an interactive audio-video telecommunication system that permits real-time communication between the two sites. We've already discussed the Ryan Height app, but this is what's really interesting about this emergency declaration in waiver 1135. And to the extent, and Rena brought this up, I think it's important enough to repeat that to the extent the waiver requires that the patient have a prior established relationship with a particular practitioner, HHS will not conduct audits to ensure that such a prior relationship existed for claims submitted during the public health emergency. So, so they're not necessarily saying it's okay, but they are not going to audit if you are out there doing your best to help your communities. So how is telehealth different in the way that we're describing them virtual check-ins? A virtual check-in pays the professionals for a brief 5 to 10 minute communications that mitigate the need for an in-person visit, whereas visits furnished via the Medicaid telehealth is treated the same as an in-person visit and can be billed using the same codes for that service. Will CMS require specific modifiers to be applied to existing codes typical of family practice physicians? And CMS is saying that no, they will not require additional or different modifiers for this under these waivers. And let's see, we've already covered that. That's a little bit. Medicaid, and again, I'm going to give a shout out to Rena because she helped and passed forward this information on to me in a very timely fashion as we were putting this together. So in response to this COVID-19 state of emergency, the Department of Community Health is waiving certain policies to help with the expansion of telehealth. So just as we said, we're waiving the original site limitations and we're allowing telehealth services provided during periods of an emergency using telephone, webcam, video call, and as Steve mentioned, while we would recommend it being a HIPAA compliant, that is, at this point, that is not necessary, that you can use FaceTime, Skype, those sorts of things. Although Skype does offer, for their business professional, their business service does offer a business associate agreement that would allow you to operate in a HIPAA compliant manner. Providers should make an effort to ensure that the communication is secure. For Medicaid, for Medicare, it's a little bit different, and they have that waiver for Medicare, but Medicaid providers are still asking that this be HIPAA compliant. The patient must initiate the service and provide consent to be treated. So for Medicaid services, they want you to get an okay, and that should be put into the medical record with the date, time, and consenting responsible party before starting. The codes that will be billed must be identified as telehealth services, and that goes back to Steve's notes on the place of service and the or the telehealth modifier. And that's about it.
Thank you, Mr. Heidish. Thank you all. It's now time for question and answer. Thank you to all the faculty tonight. Such great information, and it comes at such a right time for our practices. We are now at the question and answer portion of the webinar. Felicia, please proceed with the questions.
Yes, we have quite a few, of course, on this subject matter. So the first one goes to you, Rena. It states, is it true that the government just made it legal to use your license across the state lines? I received an email saying this today.
Yes, during this crisis period, you can cross state lines and see patients in other states.
What software do you suggest for telehealth? Do we need to use HIPAA compliant software, or was it temporarily waived by the federal government already?
It was temporarily waived that you don't have to use a necessarily HIPAA compliant. I even read something that said FaceTime could be used, but you still have to be mindful, you know, of things when you're using FaceTime. It would be a short-term solution, certainly not a long-term, and there are so many platforms out there that can help you get the job done. You know, I'd encourage you to call the Southeast Telehealth Resource Center tomorrow, and you know, they can give you a list of them. But you know, we really don't advocate one over another. Just as long as they're easy to use, we like them to be intuitive, easy to upload, and simple for the patients.
Are there any options for our risk patients, elderly, lower income, that do not have access to a smartphone or other devices that is video capable?
Well, Troy, I don't know if you know of anything about, but I have read that the telecommunication companies are going to make some provisions for the poor and the underserved and those without. So we're waiting on, and it's such companies as Cox and AT&T and all that. So they're stepping up to try to help with the underserved population. As far as devices, I have not heard, but I would think there are going to be some devices released. You know, schools, a lot of schools are putting devices into the hands of the children, so there's no reason why, as long as there's internet, those couldn't be used for connecting with a provider.
Yeah, and yeah, I'd echo that as well. And what I might too is sort of what we've seen in third world countries and really among disadvantaged populations is that it is much cheaper to own a smartphone and use it as a phone and as a computer than it is to buy a computer and a phone. And so what we're seeing is we're actually seeing greater use and greater purchasing power in those in the underserved populations. Not all, mind you, but more than you might expect. That may actually have a smartphone that you didn't realize. And that's how we can do this right now under this emergency waiver, is that if they have a smartphone and an ability to connect to the internet, that you can do this with them.
In regards to this emergency restrictions, most of our medical population do not use our portal or secure systems through Allscripts or Skype or Google. With this change, will a basic telephone call be appropriate for a telemedicine visit?
Troy, you want to address that? I think you've already talked about phone visits.
Yeah, and that goes back to that e-visit portion that is indeed possible. It's just a different code that you would be using, and it has to be patient initiated, if I remember right. And Steve, you can correct me if I'm wrong, but in that scenario, I think it needs to be patient initiated if you're going to do that. If you want to reach out to patients, you really need to do it over a live video audio connection.
Yeah, I think the suggestion is if whoever asked that question or anybody on the phone, Medicare has a specific code for telephone calls, and that's the G2012. And commercial plans have 99441, which is 5 to 10 minutes, and 99442. Unfortunately, at this time, Georgia Medicaid does not cover the telephone codes 99441 to 99442. And the statement that they put out, I guess it was yesterday, that the GAFP got, really kind of referred you back to their telehealth, telemedicine policy, which still is more stringent than CMS's. So my advice is that if you have a patient who has Medicare, use the G2012. If they have commercial insurance, it's the 99441. The only thing you have to document is that you got approval from the patient and to bill them for this, because they're waiving some co-insurances and co-pays right now. And you'd also want to make sure that you document the amount of time that you spent with them. And then there was one other thing I was going to tell you, but man, I'm so tired. When it comes to those codes, if you do have patients who call and want to talk to you, because it's patient initiated, what most of the doctors that I work with are doing are just giving the patient a specific time frame to call in on. That code G2012 or 99441, like Troy was saying, isn't really good for patients who already have an office visit set up that day. So if you already have patients who have an assigned appointment, you can't call them up on the phone and talk to them and bill that. That's what Troy's talking about, patient-initiated services. So you really are going to have to try to find a way to get those patients to either FaceTime you or Skype you for those established patient slots that you already have filled. And I think this COVID-19 thing is trying to get ahead of the folks who are, like my son's self-quarantined right now in Atlanta because he thinks he's been exposed to it. And he had to call and use his doctor, and they, we had to tell the doctor to bill 99441 because he has Blue Cross Blue Shield, and they do pay that code in the state of Georgia. Not a lot, but they do cover it. Sorry it took so long to answer. Hope that helps.
Thank you, Steve.
How can someone get accredited and get certified ASAP?
Well, there's no requirements for certification or accreditation. In Georgia. So you're good to go right now. And the premise of telehealth is just a tool for you to use with your practice. It's not it's a way of delivering care, but it doesn't need any kind of additional regulation, in our opinion.
Yeah, and the only one that I've really seen or the only group that I've seen that requires some sort of telehealth training is around the mental health area, and generally it's therapy, psychology. They do require some telehealth training, but if there's anyone out there like that or has someone like that in their office seeing patients, that they should contact their particular board and see if they're going to waive some of those requirements during this time.
I'm not certain if this question is for the two of you, so please let me know. Which patients are to be considered PUIs? Is this a person who we are testing, or can this also be a mild symptomatic younger patient who is not being tested?
I do not know the answer to that one.
Okay. That was probably from a previous speaker. And someone wanted to know, did they miss a dummy sheet that gives brief bullet points on telemedicine? Does one exist? A quick guide?
Yeah, the telehealth resource centers have resources, and if you go to the national or just go to telehealth resource centers, it's .org or Google it. There's a resources tab, and there are tons of one-page, two-page telehealth help guides that I think you would find useful.
Okay. Troy, regarding waiving copays for testing with commercial insurers, is that waiving total cost for the testing or waiving copays only? Would this waive entire cost for patients having to meet a large out-of-pocket deductible?
And so you're talking about the testing itself, it sounds like, and not so much the telemedicine visit. My understanding, and again, Steve, correct me if I'm wrong, that they are waiving the entire amount.
Yeah, that's correct. They're waiving the testing fees associated with it. And from what I've understood too, I'm reading that Medicare is going to, and I'm not 100% sure on this, and I think Dr. Church is on the line. He might send me an email, but there are typically co-pays and co-insurances associated with telemedicine, but from what I've read, it looks like they're waiving those as well for the next 90 days, as long as this is something that stays, as long as we stay under a national emergency. They're trying to get people to, encouraging them to get help. And then also,
yeah, and I think that
commercial payers, I'm sorry, some of your commercial payers like Blue Cross, not that you want to do this, but I know that if I have Blue Cross Blue Shield because my wife's a teacher, they've reached out to us as patients and encouraged us to use their cell hotlines. They have physicians and nurses that are available 24 hours a day. So, you know, if for some reason you need to get that information out to your patients as well, and they're waiving co-pays and co-insurances for those as well.
Yeah, and the only thing I was going to add is what I've seen as well, that on that waiving of fees too, I believe that as a part of this emergency, they've waived the fear of anti-kickback statutes associated with waiving fees. So you know, that's my understanding.
This is Faye, and I'm going to jump in because Dr. Wood, although she's off the call, she emailed me and said that while we were on the call, AFP set up a webpage that's called Using Telehealth to Care for Patients During COVID-19 Pandemic. And the very first question is, how do I quickly implement telemedicine in my practice? So again, awesome. AFP has a new resource.
Perfect.
Okay. And the next set of questions, how do we meet the criteria for physical exam elements to do a 99214, and what is the 1135 waiver?
Well, for an established patient visit 99214, there's two ways you can bill that code. You'll know that the first and easiest way through telehealth is as a time-based visit. So you could just document what you typically document and document that it was a 25-minute face-to-face call. If you don't want to do the 25 minutes, just remember that the physical exam isn't necessarily a requirement for an established patient encounter. So you could bill your 99214 based on the detailed history requirement and your moderate medical decision making. So if you're taking notes, the 214 history is the chief complaint, the status of 3 chronic conditions or 4 HPI, 2 review of systems, and a list of medications. And then your medical decision making traditionally for primary care is a patient with 3 or more chronic conditions that are stable or a couple unstable conditions. So if you were following up on a 65-year-old patient with hypertension, diabetes, and hyperlipidemia, you could document that visit via the teleconference the same way that you do it now in your office without doing any kind of physical exam, height, weight, or blood pressure. If, I'm not a doctor, if you feel comfortable doing that, if the physical exam requirement isn't an element that would be reviewed on post-payment audit. So time is normally how I see people doing telemedicine.
Yeah, and I might add to that, and I'll defer to Steve here on this, but part of that physical exam, so doing an evaluation of the mood or affect, you're looking at the skin tones, with a phone you could look for lesions, you can look for, look inside the mouth and evaluate the teeth, and that's sort of your limit in that physical exam piece, I would think. unless you're doing like, you could also probably look at the feet if you've got a diabetic, but it would purely be just the visual. There wouldn't be any way to really test.
Yeah, and the definition of a detailed exam for Palmetto Medicare is 2 findings from 2 parts of the body. So like Troy said, even if you were able to do your well-developed, well-nourished, no acute distress, alert and oriented times 3, yeah, Troy's absolutely right.
Okay. Another set of questions. Are you able to bill for nurses and residents, and how do you document your telehealth services?
Well, you can't bill for nurses because the E&M codes, these telehealth, telemedicine services require, right now, typically a physician, but under this new legislation, this exception, it can be a physician assistant, midwife, or a nurse practitioner. If you were doing residents, you're still doing, if you're under the primary care exception rule, you're still billing under the attending, and the resident would still be able to document the history exam and decision making. You know, Medicare now has allowed even medical students to do the history as long as the attending signs off on the notes. So there's not any documentation on this, but you're submitting the same codes. Under the primary care rule, you go up to a 99213 in primary care. So I don't know, Troy. I can't think of a specific. I can't think of a specific rule that would prohibit you billing telemedicine under a primary care exception.
Yeah, I can't think of one either.
Look, we're almost to the end of our time. We got one more question.
Yes. So the last question would be, is a physician's home also considered an origination site for an online visit with a patient?
The Medicare rule just says that you can't be in the same spot. There was an interesting question about, you know.
Yeah, that's a fantastic question.
Yeah, the question was, can I be outside of a window into telemedicine? And the response was, you just can't be in the same area. So, I mean, if I know that Troy's system, I mean, typically, even after all this is said and done, a doctor could do telemedicine in his office with patients that were not in his, or in his home, even if patients weren't, as long as patients weren't in his home. Correct, Troy?
Yeah, and I would say, I would point to psychiatry, and that it is fairly common for psychiatrists or psychiatric nurse practitioners to work out of their home and remote into community service boards, psychiatric hospitals, and provide these services, and those are covered.
Okay. Dr. Howard, that is it for our questions, but I wanted to let everyone know that if you had a question tonight that did not get answered, we will be reporting all of these questions and answers on our resource page. So please visit us at www.gafp.org under the COVID-19 resources, and we will have the answers for you there.
Okay, again, thank you very much. It seems that we've come to the close of this most informative webinar. Thank you guys for attending, and I thank you again to our faculty for taking the time out of this evening to be with us. Before we log off, again, just a quick reminder, pretty much what you've heard. This webinar will be available on the GFP website as a resource for you and your staff by tomorrow afternoon. That's tomorrow afternoon. Our website is www.gafp.org. And lastly, please complete the evaluation that was sent to you. That's very important. As we navigate these uncertain times, we want to make sure that we are continuing to receive your information and CME on topics that are important to you and to the practice of family medicine. And we, as the Education Committee, thank you. Dr. Stone, would you like to make closing remarks?
Just briefly, thank you very much, Dr. Howard, for all the work that you did to put quickly all these resources for our members. And I'd like to thank the Education and Research Committee and our education staff for all the work that they've done, too. I'd like to bottom line it by saying, listen, everybody, minimize contact, but maximize touches via virtual telehealth, phone, email, social media, And, you know, if you can, reduce the well visits, still remain within the standards of care that you practice. Practice social distancing, and for heaven's sake, please take care of number one. That's you. For no matter how noble the altruism that you display, you inevitably do more harm to your community going to work sick than staying home. If you have to step down, there's no shame in that. We'll step up for you. We will be stronger together. And let us know if there's anything else that we can do for you. Good night, everyone.
Good night.